is Anthony Elfumejewa. I am the lead scientific officer with the Africa Research Network for Neglected Tropical Diseases, and I will be your moderator for today's webinar on harnessing data for impact, strengthening data management systems and utilization in the fight against neglected tropical diseases. We have a sweet panel who will speak to various topics that will be very helpful to digest the theme for today's webinar. For those of you who just joined, we ask that you share your name and where you are joining us from in the chat. All right, so we are good to start on time. And for those of you who just joined, this is a webinar series coordinated by the Secretariat of the Africa Research Network for Neglected Tropical Diseases. Just a few housekeeping rules before we start. As is with most webinars, this will be recorded, and we will later share this on the ARNTD website. For those of you who would want access to this recording, you can find it on our website after the webinar. Now, due to the number of participants who have joined this webinar, we have disabled the microphones and the cameras. Please use the chat feature for introductions or to communicate any feedback to us so that we can act on it appropriately. You can use a Q&A feature to post your questions. It's really important that you are able to distinguish between the two. If you post your questions in the chat, we may not be able to see it in good time to answer for you. We will try to get through as many as possible in the dedicated Q&A session at the end of the webinar. Just like to share with you the different participants who have joined today's webinar. Quite an incredible mix of people from all over the world, particularly from Africa, represented very well. We do appreciate your contribution and connections with us in our fight against neglected tropical diseases so far. Today's webinar is chaired by Dr. Pauline Mwenzi. She is the WHO Regional Advisor for Schistosomiasis, soil-transmitted helminthiasis, and neglected zoonotic diseases in Africa. She supports countries in implementing the WHO NTD Roadmap 2030 and tracking elimination progress. Previously, she was director at the Kemri CDC in Kenya and has led major multi-country research projects. She holds a PhD in parasitology and immunology with advanced training from institutions including Utrecht University, CDC Atlanta, and Kenyatta University. Dr. Mwenzi co-founded the Africa Research Network for Neglected Tropical Diseases, initiated the Kemri Annual NTD Conference, and has published over 90 scientific papers. She is widely experienced in research leadership, policy, and advocacy, and supports community development in Kenya. Ladies and gentlemen, I present to you Dr. Pauline Mwenzi.
Thank you, Anthony, for that warm introduction. Good morning, good afternoon, good evening, everyone joining us today for this important ARNTD webinar on harnessing data for impact, strengthening data management systems, and utilization in the fight against neglected tropical diseases. I am honored to serve as the chair of today's session, which brings together NTD program managers, scientists, and partners from across Africa and beyond, and would like to start by highlighting that data is at the heart of achieving the 2030 NTD roadmap targets. Without timely, accurate, and accessible data, our programs risk being reactive instead of strategic. And why is timely, accurate, and accessible data important in NTD control and elimination? Data is not just a reporting requirement. It is the compass that allows us to track progress, allow allocation of resources efficiently, identify gaps, and respond rapidly to emerging challenges. And the shift from blanket interventions to precision public health requires that our decisions be guided by granular, validated data, and especially for schistosomiasis, which is the disease that I am in charge of in the Africa region. I would like to use this opportunity to highlight ASPEN's leadership in NTD data support for decision making in the WHO Africa region. In collaboration with countries on data sharing, we have invested a lot in building robust, country-driven data systems to support decision making. And the ASPEN NTD portal is our central hub for this purpose. It is an open access platform that houses geospatially disaggregated data down to the implementation unit at community level, especially for schistosomiasis, enabling countries, partners, and researchers to plan and monitor interventions effectively. Beyond being a repository, the portal is a living tool. It provides funding and intervention data for mass drug administration and surveys, and ensures visibility and transparency for both programs and partners to update and validate funding information and progress at country levels. It also integrates outputs from our tools many program managers will be familiar with and track coverage in real time. And so we've provided tangible impact from the ASPEN NTD data portal. In the past year alone, ASPEN has supported 21 M&E surveys in 13 countries using the ASPEN Collect tool, covering over 70 districts and 867 sites, with a strong focus on onchocerciasis and lymphatic filariasis, but also several surveys on schistosomiasis and STH. At the same time, we trained over 88 national and local staff, strengthening in-country capacity for high-quality data collection. In my final slide, I show that we have systems in place, but our collective challenge is ensuring that data is used, not just collected. This means timely validation, integration into national health information systems, as some of our speakers will show, and active use for micro-planning, impact assessment, and advocacy. And ASPEN remains committed to working hand in hand with countries and partners to ensure that every data point counts towards elimination. Today's webinar is an opportunity to share lessons, explore innovations, and strengthen our shared commitment to data-driven NTD programs. And I encourage everyone to think about how the approaches we discuss can be adopted and applied in our local contexts. In closing, I hand over to Anthony now to welcome our keynote speaker, and I look forward to a rich solutions-focused discussion for today's session. Thank you very much for having me.
Thank you very much, Pauline Munzi. As always, brilliant delivery there. Happy to hear all the tools and resources that are available and accessible for program managers, implementers, and research scientists in the NTD space. Remarkable start of our webinar. I would like to now introduce the Executive Director for the African Research Network for Negredical Tropical Disease in the person of John Amoesi. He is the head of the Global Health Department at the Kwame Nkrumah University of Science and Technology School of Public Health, and he leads the Global One Health Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine in Ghana. John is a W2 professor of Global One Health in Germany at the Uniklinik in Eppendorf, and he's an adjunct professor at the University of Minnesota, a visiting research fellow, at the University of Oxford. With over 20 years of experience in tropical medicine and global health, including malaria, NTDs, AMR, and One Health, he advises global organizations on access to medicines, and research strategies. Ladies and gentlemen, please let us receive Dr. John Amoesi.
It's really exciting to engage with this webinar, and I must mention that we cannot do without data in our fight towards eliminating and even eradicating NTDs. It's so critical that the data that we have is reliable and directly informs policies and other interventions that are aimed at achieving our 2030 targets and beyond. What this means is, as our eyesight improves, i.e. we have better data, we'll be able to understand even more granular detail the situation in which we find ourselves and what it's going to take to really achieve the targets that we need or we have purpose to achieve. It also introduces a bit of a challenge because the more closely you look at the better you can see, the more things you will find which you did not know existed. And what do you do with these? What this means is it's ultimately some kind of a shifting goalpost of some sort. That is, you have better data, you have a better idea of what the real situation is, and you may have to adjust your timelines. But all in all, once you can achieve that clarity and that confidence, you know what to do, when to do it, and where to do it, then you're on the right path, and that's what data will do for us. The next thing I'd like to emphasize is the need to strengthen national data infrastructure, particularly for NTDs. Now, when I say particularly for NTDs, I'm not trying to suggest we need a unique and bespoke data collection system only for NTDs, but making sure that NTDs are integrated into a wider approach, broader approach of collecting reliable data across the board. And this is where I advocate strongly for a One Health approach towards data collection and making sure that the data we collect from the human sector, from the animal or veterinary sector, from the environmental sector, is all interlinked in such a way that we can pick out what is most relevant to NTDs and also be able to understand better how an intervention aimed at NTDs, let's say some of the MBA exercises we conduct or the classes that we conduct, what the overall impact would be beyond NTDs and on the health system as a whole. I cannot overemphasize this need for strengthening of national infrastructure, but also it should be done in a way that is cohesive at a regional level, at the West African level, at the East African, at the Central, the Southern African level, Northern African level, and ultimately at the African level. And this is where we look to the leadership of WHO and the Africa CDC to support in making sure that we have these systems. And the ARNTD, as a primarily a research network, is ready to support, to provide the rigor and the science that is needed to set up these systems and to collect the information, translate it into knowledge which policymakers and actors can use. Another point I'd like to make is the need to strengthen our data visualization capacities, which is being able to project that data, synthesize it, and project it in a way that is appealing to the eye and also makes immediate sense, that is intuitive. There are several platforms that have been used more recently, including GIS-based platforms and several others, dashboards of different sorts which allow you to combine data sets and to visualize different geographic locations. All these are very, very powerful tools that can be harnessed and leveraged in the fight against NTDs. And I believe that as we become more and more advanced in these tools and they become more and more integrated and interoperable, even at even behind your laptop, you should be able to really generate very important visuals which can be used for teaching purposes, which can be used for policy development and for tracking and monitoring purposes. The final thing I'd like to speak to is the ethics of data collection and the issues of equity in data collection and ownership. As you know, in the 2030 roadmap, counter ownership is big. I can't overemphasize how we need to make sure the data is being collected in an ethical manner and also in an equitable manner, in that it truly reflects the geographic regions in which the data is being collected, because it will be a huge error to generalize information to wider areas where it may not apply. And it's also critical that this data is protected in a way that it cannot and is not misused, but at the same time that it's still available and accessible to those who need it the most, including the scientists and the policymakers. The ethics in data collection, especially as we move into more interoperable systems, as we apply artificial intelligence, and as we triangulate different pieces of data which will be collected in a routine manner, especially when we're looking at passive surveillance, is very critical. The discussion is ongoing, and it's really important that this is debated, discussed, but in a very constructive way to ensure that ultimately the data is available, accessible, it's open, it's useful, and it's also safe. With these, I think we can dive straight into this webinar. I'm excited about it already. I'm looking forward to the presentations and the ensuing discussions, and also to the questions that we will have for our esteemed speakers and panelists. Thank you very much. I'm looking forward to connect with you today.
It was an address from the Executive Director of the Africa Research Network for Neglected Tropical Diseases, John Amoesi, who just delivered his speech to us. We like to remind you, as the speakers begin, please do well to put all your questions that come up in the Q&A. And for those of you who joined late, you can still introduce yourself, tell us who you are and where you're joining from in the chat. We just do highly encourage that you do not mix this up so that we can find your questions and answer them in good time. To speak to the issues next will be Chooks and Christian, and they will speak to enhancing digital platforms, GIS tools, and interoperability with national health information systems. Chooks Okonkwo is an epidemiologist with over 20 years of experience in public health practice. He is the immediate past implementation manager at the USAID RTI Act to End NTD East project in Nigeria. He is passionate about the use of data and innovation approaches for NTD elimination in African communities. Christian Wonsu is a public health practitioner with interest in neglected tropical disease control and elimination, digital health, mHealth, research, and geospatial epidemiology. He has over 15 years experience in development sector and managing programs. He is involved in rolling out innovative digital tools for quality management and visualization. Ladies and gentlemen, I present to you Chooks and Christian.
Thank you, Tony. I am Chooks. Christian will take over from me once I'm done. I want to appreciate the background laid by the executive director and the chairperson. They have done half of my job. So I would like to just go straight forward to the presentation. Now let us discuss these 4 things. What have been the issue with NTD data as we know it? What progress have been made on the use of digital platforms and GIS tools? Some of us are already aware of these names: Kobo Collect, ComCare, ODK, SDK, DHIS2, and so on. And what are the challenges? We will be talking also on the interoperability with the National Health Information System. And then we will look at the way forward in strengthening NTD data system. Now, the structure you are looking at is a traditional setup of data flow in most African countries, because we have always had this geographical and structural pattern that most countries have. In Nigeria, we have the federal, We have the states, we have the local government, and then within the local government, you have the wards, some of which contain the health facilities, and these health facilities service the communities. So this is the structure that define our data flow. And so at each level, there is a tool, mostly paper-based tool, that have been in use all the years. So we have so many tools that feed into each other. And this increases data entry error. It increases the delay in data reporting. It increases all manner of gaps that data systems have been facing over the years. So what have we done? The issues with data system, as I mentioned earlier, largely paper-based, fragmented and siloed data system, delays, data quality problems, due to so many people entering data at different layers, different levels of reporting, and so on. There are many, many issues. Even internet access, low literacy level at community level, has bedeviled the data system over the years. What are the progress that have been made on digital platform and GIS tools? I'll be sharing a number of examples, especially from Nigeria. Some of these examples are very community-based. They are coming from the field. And of course, to achieve real-time monitoring, all the issues that have challenged data system, tracking of medicines, rapid identification of gaps, improve data accuracy through automated data quality checks, reduce data reporting delays, faster decision-making and response. It has become necessary to transition from that paper base, which obviously is going to cut off or boycott some of those structural layers from the community level where data are collected up to the national level. And then we cannot do away with the GIS tools for disease mapping, the hotspots identification, and then targeted intervention. So let us look at some of these examples from Nigeria. These examples cover both MDA and surveys. Now, all right. So we have used on the field in Nigeria different applications, the ODK, the Kobo Collect, SDK, to monitor real-time MDA on the field, treatment on the field. What this does, what happened is that you are able to see the gaps in coverage real-time and intervene real-time. And while doing so, we have also collected coordinates, which was used to generate map of community treatment and supervision coverage. The very last one I participated in was in Cross River State, a very hard to reach, that has very hard to reach location, where treatments hardly happen because of the terrain in that state. So, but with data, with digital platform, we've been able to monitor, supervise, track challenges on the field. We monitor dashboards real time. And when the maps, the GIS, the coordinates were used to generate a map, you can see clearly where was covered and where wasn't covered. And so this also informed the follow-up activities. Likewise, we have had during treatment, as I mentioned before, some of these locations hardly had people willing to go there. So, and especially communities that are riverine. That state is a very riverine area. And so we have people, because we have been able to use digital platform to monitor, to supervise, to track. We have people who have taken this drug for the first time in so many places. And what follows was a lot of drug reaction. And therefore, using the geocoordinates, we were able to generate a map of where these reactions happen. The map beside this picture is a map of where reactions, drug reactions happened. When we superimpose this map on the water system in the states, you can clearly see the pattern. The pattern follows the river system, telling us that the population along the river system are hardly treated. These populations are usually in very hard to reach terrain, difficult to reach terrain. And so this therefore informed program shift and approaches. There's still a discussion around conducting operational research to find out what factors could have added to such a huge number of drug reaction in these communities. And as I mentioned, we have this issue of hard to reach location where implementers hardly go with the drugs. And therefore, what happened was to use the drone. Look at the video you are watching is a drone delivery of drugs in communities where intervention hardly gets to. So these are all the innovations, the progress on digital platform and GIS tools that are applicable for the improvement of data, in Nigeria. I would want to ask Christian to take over from here to discuss the DHI's approach in Nigeria. Thank you. Christian, over.
Thank you very much, Chooks, and hi, everyone. My name is Christian Wosu, and I work with Site Savers, Regional Technical Lead. Just like Chooks said, just a rider onto what he said, and then looking at broadly speaking around data, how data has contributed to the progress that has been made so far. I mean, digital systems have made so far in NTD implementation. And I just want to write on a couple of things that had happened earlier on, like Dr. Pauline did say earlier on, and also Dr. John did say earlier on, data kind of drives the processes of what we have to do in NTDs. And on that ground, some practical examples we have had is one in the setup of a DHIS2 system. As we do know, DHIS2 is one of those systems that a lot of countries and a lot of programs have adopted for data collection, data visualization, data quality. And it's one system that has really helped in kind of building a robust system, robust data approaches. And so that was one system that's been used in Nigeria and across other African countries in NTDs, where like what you see on the screen here is one of those systems where NTD treatment is being monitored online and reporting is being done across different places. Currently, this has been deployed in about 17 states in Nigeria, or more, about 17 states in Nigeria, where this is currently being used for reporting and monitoring treatment as it's going on. And so some of the key successes that we've seen around this is around improved data accuracy and reliability. Also, in terms of faster response times and better decision making, which has helped a couple of programs to be able to look at what has been reported in previous years, what has been reported in current year, and just to see how things have been progressed. So this has been on for a couple of years, starting around 2019 and until now has been is still being improved. Then moving on from there, it's something that has been so dear to us in Nigeria. It's a system that the Federal Ministry of Health, just like Dr. John was talking around issues, talking around building a system where more of a centralized system that would drive the process. So this is something that has been developed in Nigeria, where we now have a system that is currently ongoing and being developed, where you're looking at one system where everything does come in, and then like a repository, what we call integrated NTDs data repository, where all data that relates to NTD is in one platform, is in one system, and something that if anyone requires to use any data, if the ministry requires to use any data, it's able to access that data in a central location. And good enough, this is now being driven by the ministry. This is not like driven just by partners, but partners supporting the ministry to be able to drive this process, drive this system. So what they're trying to do is to now look at all the things that have to do with interoperability. And we have the NTD wash merge that we bring data from NTD and wash, and then pull it into that system. Issues around drug inventory, pull it into that system, entomology, pull it into the system from a spend portal, surveillance, MMDP, DMDI, all of those whole systems, pull it into one place where dashboard, there's a dashboard that will now be used for visualization, looking at quality, also looking at generating reports around JAB and APREF, and the TEMF and reporting forms can actually be used to generate. So this is where the country is now tending towards. All of these are not without challenge. There are a couple of challenges that we do know that digitalization comes with. And one of them is that at the beginning point, and even until now, there is still that partner-driven focus where you have where each supporting IP implementing partner wants things related to their focus to be included and all of that. This is something that we have seen. This is something that is also being managed currently, especially with a new system that is coming up. So it's something that's now being managed properly to see how to make sure that all of this doesn't become part of the things that will block the continuity. But those were some of the challenges that have been identified. And then also there are things around what kind of pre-information do we need to load into systems, right? I do recall that when we first started around the DHIS2, one of the things challenge we faced was around community listing. It's something that created a lot of challenge and all of that. So it's a challenge that needs to be addressed and has actually been worked out to be addressed now. Then also we have inadequate capacity at various levels for system management. Now, while we look at digitalization as something that is good, something that is nice to be able to go through, the NTD system, the NTD team in any place, in any country or a given group needs to have a system management team that will be able to support this process, not like the what we have like in terms of those really implementing, but a group of team who are going to be focused on system management. Then, like Chicks also mentioned earlier on, there's also the challenge of poor internet coverage in most of the countries, most of the communities where work goes on, where data is being generated from. And then also the complexity of some platforms around and mixed joining up with the central system where data will be kind of getting into. There's also that complexity. There's also limited accessibility in terms of the different system that is available, and also inability of programs to be able to kind of fully harvest and use data that has been uploaded, data use now. So besides having a digitalized system, I think one thing that needs to really be promoted is around data use. Dr. Pauline did mention this earlier on about data use. I think it's something that we need to also begin to look at. That's actually been a challenge that is around digital platforms. So it's not just collecting the data, but it's also the culture of use of those data without having to return back to previous systems and all of. Then also the cost of scaling and maintaining these digital systems, as well as budget constraint, is some of the things that we have actually seen around digital platforms. I talked about the interoperability also. This is something that we have seen. I did mention earlier around the data merge, and also the current system the Ministry of Health in Nigeria is building, an NTD system is building currently. So this is something that's actually being being promoted, and there is high need for cross collaboration because it's something that is really going to help these systems to be able to have the required data and also be able to have the required information to be able to make decision and moving forward. Way forward around this. One of the things is to improve government ownership and support to digitalization. This is one thing that we think that needs to happen in terms of improving government ownership, and then secondly also increase capacity of digital system personnel within the NTD sector. This is really becoming very needed to strengthen data systems. So we need personnel, digital persons who are digitally inclined to come in within the NTD sector to promote and increase the capacity within the NTD sector, and also to promote a centralized system for all NTD related data. Just like Dr. Pauline did mention, the Expend portal is one portal that has really been very robust, has a lot of data, treatments, entomology, and all of that you can think about. They're all in those systems. So it's something that we need to be able to begin to promote this centralized system. And as Dr. John also did mention, having one system, not just an isolated system, but a system where it's within an existing system where it continues to be managed by the ministry, and also explore cloud-based solutions for storage and access. Right, it's something that also needs to be looked at very closely, because the storage systems is very important as we get into all of these discussions. Then leverage AI, as we see it's happening, and machine learning for predictive analytics, and also for NTD surveillance. Call for immediate action, something we need to start looking at, invest in digital infrastructure such as phones for field officers, and then build data literacy, continuous capacity and building for field personnel. Thank you, and over from me.
We are still taking your questions, and we do recommend that you put your questions in the Q&A for questions that will come up during the presentation, so that you do not forget these questions, and also give us the opportunity to ask these questions during the Q&A session. On that note, I would like to introduce the next speaker to you. Maria Magdalene Namaganda from the Makerere University will be speaking on ethical and practical dimensions of NTD data, governance, privacy, and innovative approaches to collection, integration, and visualization for policy and practice. Maria is a bioinformatics and data science research scientist working at the intersection of global health, genomics, and data science. She's currently pursuing a PhD through the Makerere University Data Science Research Training Program, and is a WHO TDR Clinical Research Leadership Fellow at the University of Oxford's ISARIC Group. He's an inaugural scholar in pandemic preparedness at the Institute for Global Health Sciences. Maria leverages health data and AI to transform public health systems, particularly in resource-limited setting, while championing mentorship and the rise of Africa's next generation of scientists. Ladies and gentlemen, I present to you Maria. Over to you, Maria.
Thank you so much, Anthony. I am so privileged and happy to be with all of you this afternoon. Good afternoon, good morning from wherever you're listening in. And I would like to dive deep into what the discussion for the day is. The previous speakers have done a wonderful job in breaking down what the topic and our points of discussions are. And yes, for this session, I will look at the ethical and practical challenges of governance when it comes to NTD data. And of course, I will share innovations and best practices in NTD data collection, integration, and visualization for policy and practice. Now, I need to make a disclaimer that most of my work and what I've been doing is skewed in HIV data research. But when it comes to data, we don't look at it in isolation, because some of the practices we use in HIV can be integrated in other sectors like neglected tropical diseases. And we've seen the previous tools that members have shared, including the ESPN tool or database that covers most of that data when it comes to neglected tropical diseases. But one thing that stands out for me at this point is looking at neglected tropical diseases, not just as rare diseases, because oftentimes we've seen that areas like HIV and other disease infections like HIV, like TB, are indeed heavily studied. But when it comes to neglected tropical diseases, when it comes to NTDs, they are not just prioritized in some of these instances. And when I was looking at the map at the ESPN, I saw some of the areas that are highly affected, and that includes the poor or the low resource settings, even when it comes to the Ugandan context. And this includes areas that are not as easily accessible as we've seen. And some of these, of course, diseases are really linked to things like the way of life and also the different issues that are there. When it comes to, for example, in Uganda, which is a country I come from, diseases like onchocerciasis are very prevalent in regions of Busoga. Schistosomiasis are common in northern Uganda. And so some of the ethical and practical challenges that we've seen when it comes to NTD includes issues with fragmentation or the verticalization of the data, where most of the programs are actually running independently of each other. Yet, when we look at the spread of some of these diseases, we notice that in the areas that we have onchocerciasis, we have diseases like TB, like malaria, and these other things. So looking at systems, not in isolation, not in fragmentation, but looking at them as systems that can be integrated to communicate. Because when you look at data, one variable can help better give you insights into a situation or a condition, or give you better outcomes when it comes to patient management. For example, in Uganda, there is the Ministry of Health that deals with mass drug administration, that is the MDA, but that entire system is quite independent of institutions like the Ministry of Water, which caters to the water and sanitation, risk zones, and then also quite separate from the Ministry of Education that caters to the school deworming. And you can notice that at some point, there is a common denominator here. For example, if it is a child, a girl child who goes to school and they are in the WASH risk zones, they are also into the deworming program, and somehow their data points are separated. They do not communicate to each other. So there is that kind of gap and missingness that is not easy to follow up. And then when you look at some of the data ownership and consent issues, this is a huge topic that, of course, needs a lot of attention and detail. But we've seen that most of the programs, when it comes to NTDs, are donor-driven. And as such, the data capture is really focused on the interests of the donor. So this, at some point, is a challenge because it does not necessarily serve the community themselves the way this data is collected. Because when the donor comes, the donor has a particular agenda, and that is the data that is being focused on. So some variables that could give insights into the way of life and maybe other co-infections are not necessarily given that much attention. And then when it comes to studies of NTDs, we've seen that there is weak data privacy when it comes to programs like mass drug administration, where they are performed in the communities. Some of these people do not understand what this data is for, and the consent is often assumed. It is not entirely explained to these people. And because we looked at some of the areas as areas that are illiterate, they don't even understand what is going to be used, what the data is going to be used for. And that creates a gap in how much information we can collect from such facilities. So things to do with data consent, privacy, and also some of the ways that data is collected is on paper-based formats. And that means even the storage, because it's not a stigmatized kind of study like you would look at HIV, some of the information is actually accessible and identifiable in the small communities. They have information such as their age, their homes, where they stay, and this is not securely stored in some instances because, again, it is not, sometimes there is a weak link when it comes to that data privacy and the consent And then when it comes to, of course, some of the representation gaps that could be programs that run when maybe targeting particular schools locally or in different national programs, that children that do not attend school on those particular days miss out on the program. But how are they really followed up, or is it just left out to chance that they missed out? And this is how we see the reinfection emerging, right? Again, issues to do with like mobile workers. And of course, there are so many issues we could talk about when it comes to loss to follow up of some of these. And then when you look at some of the quality and timeliness, because most of the times the data, when data is being collected and the people from whom the data is collected don't understand what it's going to be used for, there is a miss in how much people get. And so there are issues like missingness. We've talked about the paper-based reporting, where transferring data from papers to systems creates data leakage in some form or shape. And this affects the downstream analysis for the people that get to interface with the analysis that happen after that. And yeah, but I would also say that we can, of course, do so much when it comes to neglected tropical diseases and data and some of the practices that are happening. And one of the things that I could think about is the data capture. The previous speakers have emphasized so much on digitizing, but I would say digitizing at the source of the data, which we've seen like with the drones and all this information that is being collected with the JSI tools. But importantly, to digitize this and connect and link the data systems where, let's say, each patient has a unique identifier, or each person from whom the data is being collected has a unique identifier that can be linked to the national systems and can be linked to other programs such as HIV research, malaria, in a sense that when people are doing analysis or they are doing like the downstream processes to this data, they can link to this one patient and say, okay, this is from this region, which is highly affected by, let's say, trachoma or rabies, or, you know, that kind of integrated access of data just from the point of data collection. And then looking at issues when it comes to data harmonization, and of course, using standard capture forms where we can communicate with the data. The data can speak to each other, to not look at it as independent formats, but this will enable increasing the quality of the data and also flagging some of the recontact people in the communities. And of course, when you look at data harmonization, we cannot skip looking at the data quality that is happening at all these different levels. And then when it comes to visualizations, having dashboards that speak to the population and also reflect what is exactly happening on ground in a way of returning insights from what data has been collected, but also for these visualizations and dashboards to be highly accessible to all the researchers, to the health workers, to the village health teams, because these are the ones that are mostly involved in some of the work that is happening in neglected tropical diseases. In a way, they've talked about supply of mobile phones and internet access. Some areas in Uganda still don't have good internet access. So these things all help to bring awareness to the people from whom the data is collected and how this data is used in the downstream analysis, because this informs the research that is being performed and done, and also, of course, helps in risk predictions. For example, there is a big talk about AI and machine learning, and all this really depends and bases on big data. But big data is just not enough. It has to be clean data, because once you have poor or data that is not representative, then of course that reflects in some of the outcomes. And so the data doesn't just have to be big for the visualizations, for the analysis, but it has to be clean data. And the follow-up has to reflect in those instances. And then, of course, when we look at, I thought of a framework that we could perhaps reimagine when it comes to data governance. And I'm calling this the 5R framework, where we look at representation, who is being counted when it comes to some of these surveys that are happening on ground, who is being counted and how are they counted, and have they consented? Yeah, that like feeds into the rights. Who owns this data? Is it the communities? Can people researchers have access to this data? The national programs have full access to some of this data, not just let's say the donors and things like that. And then, of course, when we look at the reach, is the data linked to like real-time service provision, and look at some of these areas that have low internet connections, they are not accessible for some of the maybe road transportation. Can we use this data for policy, but also the data, linking the data points, some of the real-time service provision as a nation? And then when it comes to responsiveness, can the data guide community level decision-making in terms of providing, of course, the feedback loops, and the community can be involved in the process, so they can also provide better data. And then when it comes to resilience, things like the data systems that we have, can they stand the test of time across outbreaks, migrations, funding, transitions? As we've seen there is a whole talk about the funding when it comes to research in the world. So can some of the systems we develop stay resilient and survive through all this? And then as I got to conclude, I would like to say that this is maybe a call to action, or a way to say we can, of course, build neglected tropical disease data systems, but then we need to think of it a long term, and to design systems that talk to each other, systems that are not vertical, but systems where data is harmonized and information flows seamlessly across all these different programs, across policy, and this will allow for response to interventions. And of course, we can do this through listening to the communities, making sure they are, for example, the consent forms are kind of transferred in their local languages, in the language that they understand, and ensuring that their realities really shape the numbers we see, moving beyond the vertical disease silos, the fragmentation in the health systems, and also to have a community where every data point works for the whole system, not just a single program, because behind every data point is a patient with a story who needs assistance, who needs help, and who needs better care. So we need to treat every data point as such. And of course, maybe a call to action for the people that are interfacing with some of these communities, to make sure that they explain to the people, so that we can collect as much data as we can. Because when it comes to, again, fields like artificial intelligence and machine learning and predictive analysis, we need a lot of data points, a lot of clean data points that can help us give better predictions, mapping out some of the areas at risk, and information related to the same in combating and eliminating neglected tropical diseases. Thank you so much for listening to me. I will end my presentation there.
Beautiful storytelling approach by Magdalene. Thank you very much for a sterling presentation, as always. Without much ado, I just would like to remind you that the Q&A is open for your questions. And so far, we are collecting questions for the respective presenters. We cannot promise that we will be able to address all the questions, but we are trying to make sure that, you know, these questions are compiled in a way that addresses the spirit of the questions, and hopefully we are able to buy some extra time within this time limit to answer any other follow-up questions that may come. Dr. Nana Kwadwo-Brichum, currently an independent technical advisor, will be speaking to how to foster collaboration and data integration across sectors to advance data-driven decision-making in NTD programs. Nana Kwadwo-Brichum is a seasoned medical and public health professional with over 20 years of experience in disease control, epidemiology, and health system strengthening. He has held senior roles with the Ghana Health Services, the WHO, Bill and Melinda Gates Foundation, GLIDE, and USAID, contributing to the elimination of neglected tropical diseases across sub-Saharan Africa. Known for his strategic leadership and scientific rigor, Dr. Brichum brings deep expertise in school health, WASH programs, maternal health, community pharmacovigilance, and infectious diseases of poverty. He continues to support public health innovation as an independent consultant. Outside of work, He is devoted husband and father of 3 who values family time and stays active through regular workouts. Ladies and gentlemen, I present to you Nana Kwejo Brichu. Over to you, sir.
All right. Thank you very much for the introduction. When you mentioned 40 years, I almost said, but I'm not even 40. But anyway, thank you very much. And I start. We all know that achieving the roadmap goals depends on emerging opportunities for integration that's supported by accurate, timely data and a strong data to action pipeline that also guides decision making across health systems. Preventive chemotherapy, in which I have done much of my work, is a central strategy for actually eliminating key neglected tropical diseases such as SDH, schisto, LF, onco, trachoma, which is well known to everybody. And that requires robust data systems for effective planning, implementation, monitoring. Sorry, my okay. The lag is, and because I want to be able to stick to my time, I'm talking a bit fast and well ahead of my slides. So data actually needs to span multiple levels and demands diverse partnerships, as well as alignment and harmonization to achieve maximum programmatic impact. All right, so we would want to look at it based on some facts that we have, and one of them, the first thing for us to note is that NTDs does not actually exist in isolation. Their causes and solutions cut across sectors. Working together allows us to be able to share resources, reduce duplication, and address the root causes of diseases. And we also think about school health or deworming programs that are also linked to the WASH interventions, or One Health approach that also connects human health, animal health, and environmental health. These are all integrated models which have been proven to be scalable and more cost-effective. These partnerships, as you would agree, pivot on leadership and governance. It also pivots on systems for data collection. It hinges on how we analyze the data and how we finally use the data for decision making. There are examples of partners. We have various partners that have supported various platforms and initiatives. And this has been mainly based on partner interest and also funding. Alignment between partners and particularly national programs is key to the success of such partnerships, especially when national programs are allowed to lead the process and to indicate which areas of support, not support the challenges that they actually face, and even prioritize those challenges, because national programs tend to face many challenges, but they need to be prioritized based on the importance, based on how impactful those priorities are on the program. And so partners supporting platforms, this is actually possible because strong partner support from WHO and ESPN have provided policy guidance and also help manage platforms like ESPN Collect, the WHO ESPN portal. The USAID has also supported the DHIS2 integration, and some analytics training, which is also key. The World Bank has funded some digital health infrastructure, the Gates Foundation, GLIDE, amongst others, have also provided innovative ways of mapping and elimination doses, because many of our countries are also rich in elimination of some of the diseases for which dossiers are needed for verification. However, all this is based on data, and the support of various partners is required for programs and nationals to be able to acquire that data to populate or use in these dossiers for or verification, depending on what we're talking about. But largely, many of the programs that we are implementing, especially for the PCNTDs, are they've been earmarked for elimination, for which reason verification has become kind of the order of the day. So one of the important partnerships that I want to cite as an example is particularly for historical significance was the CDTI partnership, which made tremendous achievements, but not without challenges, and has undergone some process of is a transformation or evolution, and has now transitioned into another form. But the key elements of CDTI remain. So community-directed treatment with ivermectin is actually a model of effective partnerships. And WHO APOC MEC led the global coordination with as a technical group and also drug donation group, whilst ministries of health helped to integrate CDTI into the national systems. NGOs like the Carter Center, Site Savers, CBM also provided technical support. But let's note that CDDs were actually in the driving seat because they delivered the treatment in the communities. They filled the registers and provided the reports from the communities. This strategy was able to reach millions across Africa and has led to the reduction in blindness and strengthened local health systems. And also currently, it's also supported the drive from ONCO used to be a control program, but now it's transitioned to an elimination program. But the important thing is that we should be able to sustain the gains that were made by this process. The name has changed. We cannot call it CDTI because it's no longer just ivermectin, but community-directed treatment, the engagement and involvement of community members in ensuring that this treatment approach is successful, even for schistosomiasis and other school-based treatment programs, is just as essential. So it actually helps, it has some challenges that remain, such as sustaining the motivation of the communities, motivation of incentivizing the CDDs for them to be able to continue doing the work, the good work that they've been doing, securing long-term funding and closing cross-border gaps. If I'm treating my community and the next community is not treated, the likelihood that I'm going to achieve elimination in that country becomes very, very, very limited. And for which reason, cross-border collaboration, even across countries, becomes very important in implementing MDAs. Part of the challenges, some of the challenges are also the fact that we need to be able to secure long-term funding for our community-based activities. Community-based registers, as we have them now, may have to be digitalized in the very near future. I know there have been some efforts in the recent not too distant past or recent past to actually digitalize community registers, but this needs to be strengthened, or we need to make sure that this actually happens in the current world as we have. Mobile phones or cell phones have been used, and all this requires the support of partners. So partners actually do identify areas of interest, but need to still work with national programs and communities to be sure that these interests are well aligned with them before we can go forward to address them. One Health is also a typical example that has demonstrated great partnerships by bringing together human, animal, and environmental health, as the ARNTD director alluded to. So ministries of health actually work with the One Health partnership. Also has this fair share of achievements, and also, but is riddled with a lot of challenges. I worked in the national program at the national level for at least a decade, but there was little or no collaboration between health or our programs, the NTD program, and then the agri sector or the veterinary sector. But there are several diseases that have implications for animal health and also human health. A typical example is rabies. But how do we deal with rabies? Is it for the animal health people to take charge and control and lead, or it is for the Ministry of Health to take that upon themselves? Now we also have the integrated skin NTDs, which is showing great leadership in ensuring that skin NTDs are addressed. And it has been supported by a huge WHO framework that is also led by ministries of health, NGOs like ANESVAD, I think HKI, Site Savers, you name them, that have made great achievements, which includes the combined mapping for yours, leprosy, brucellosa, even mycetoma and scabies. And this has also unified training for the public health care workers, primary health care workers. And it uses diagnostic mobile apps that helps to break some barriers of funding in silos and lack of rural expertise, and also addresses poor HMIS integration. Integrated indicators like the DIMS2, running mobile clinics and using multi-disease supply chains have been promising solutions to the integrated skin NTDs or skin care. I mean, having been through these two important examples, I can say that we have made some progress. NTDs have made tremendous progress through the partnerships that have been established, maybe for decades, we can say at this time. And many countries have actually achieved elimination milestones. For LF, Togo led the way, Malawi, and other countries in the Asian region. Trachoma, we talk about Ghana, yay. And then Morocco, Mali, and then Morocco, Mali, and Onco also in Niger. Ecuador and a few other countries have also broken the transmission of onchocerciasis and have been verified to have eliminated these diseases. These are successes and or outcomes that we need to be very proud of as the NTD community. And all this has been achieved through the strength of partnerships. various partners, global or international partners, and national programs have taken their rightful positions in these partnerships to ensure the success of their programs. And it can only get better, and we should continue to work towards that. When we also look at data systems, data systems like the DIMS2 and the SPIN Collect, the WHO NTD portal, have allowed integration of NTD indicators, and these platforms have actually allowed or enabled the integration of NTD data, and also provide real-time access to data for decision making. So it has, when we talk about DIMS, it makes possible integrating DIMS data and immunization data through that platform in order to avoid duplication. But the strength of all the programs are not the same. The strength in terms of funding, in terms of technical support, tends not to be the same, and for which reason many health workers tend to be attracted to the better endowed programs. And so even if they work at the district or sub-district levels where this data is available through the hospital systems or wherever you find them, they tend to pivot towards the better endowed programs, making sure that their forms, harvesting of that data is done well in order to pass it through the DIMS, while the NTD program may suffer. Platforms that make available data, platforms where data is shared, platforms where best practices are shared. We have a typical example of Kikundi, which is a perfect one where program managers actually meet regularly and where the platform serves as a peer learning network for program managers. It supports some best practice sharing and problem solving. And the regional alignment with the WHO is also a point for discussion to ensure that the goals of the WHO roadmap are achieved by countries. So far, achievements are such that they've had regular, the program managers on that platform have had regular technical exchange and shared tools and repositories. And however, I am sure that it's been functioning not without challenges, and this requires that this has led to challenges such as uneven engagement, internal issues with internet connectivity, as has been alluded to by previous speakers, and funding sustainability. I don't know how long funding for this platform is going to remain, but I do know that the Gates Foundation did help in establishing, did help in launching this platform, and I'm sure they still are heavily engaged with them. Other partners may require the support of other partners, and I think there were other partners that were also supporting the platform to ensure that it functioned well, because data was key and essential to this platform and provided the learning that the program managers actually needed. So, having said that, there are common achievements and challenges that partnerships generally have, and some of it may include expanded coverage as an achievement, expanded coverage through joint delivery, harmonized tools, stronger community participation, and scaled digital M&E and increased national ownership. These are well-known achievements that some of these partnerships have been able to progress or advance. But at the same time, the challenges such as fragmented data systems, vertical funding streams, and issues with interoperability, inconsistent data quality, and misalignment between donor priorities and national strategies still remain. So at this point, I would like to conclude by saying that yes, to achieve NTD elimination, we need integrated data systems anchored in strong national leadership and partner alignment. Investment in digital tools and transformation and analytical capacity, both for simple analysis on programs and also for complex analytics, are very, very, very essential. And for these, and also for these, donor support and partnership is required. Donor reporting should be well integrated into the health information systems, and primary healthcare must be fundamental or the foundation for sustaining the progress of programs. For me, I wish to see that the future of programs, NTD programs, towards achieving the goals of the 2030 roadmap it pivots on things like having a fully interoperable real-time NTD ecosystem across Africa that's supported by strong governance and empowered by local decision-making. The importance of South-to-South collaboration should be identified and emphasized through platforms like Kikumdi, and these are actually key. Sustainable funding and embedded in capacity development are also pillars of this vision. And partners should be able to identify that and enforce it as well. On that note, I wish to say thank you to all NTD program teams, partners, and communities that drive this work towards cross-sector partnerships and also ensuring that we're able to reach the 2030 elimination targets. I think we should need to be able to continue collaborating to make integrated data-driven decisions the norm, because that is the only thing that can get us there. Thank you very much. And I can see Anthony's face, so thank you.
Thank you very much, Nana Kwejo Brechu. I loved and enjoyed how you synthesized various aspects of what has previously been presented by other speakers, and just allowing us to see things for what it is, and comparing some of the strengths of what existing programs have been doing and how we can just forge on an integrated approach. We'd like to also thank you very much, Maria, Christian, Chooks, John, and most importantly, Pauline, for your time on this webinar. I can assure you that there has been a very thorough Q&A session happening right now, and already some of our panelists are in the Q&A answering questions that has been asked. I'd like to take this opportunity also to ask our other panelists to check in the Q&A for those that we can answer through the chat. But we have received quite a number of questions, and it would be nice to answer those questions so far. Perhaps my first question will go to Chooks. Chooks, someone wanted to know if veterinary departments in Africa have a data management system for data collection and sharing. That's an easy one, if you can speak to that.
Yeah, thank you for that question. I believe this is the fragmentation we're talking about. I believe every sector has a kind of siloed data system. But because of the interoperability limitation that we are trying to address here, these are usually not very visible. The person asking the question can relate with the veterinary department. I believe that there is something they could share with him. And if we begin to promote interoperability, this is something that we can all have in one place, speaking to each other, data shaking hands across sectors, and we are able to make informed decisions. Thank you.
Thank you very much, Chooks. One very important question here for Christian, and the question is, what is the feasibility, efficiency, and sustainability of this approach when implement? Oh, sorry, I was hoping to. Sorry, the question actually says that what challenges exist regarding digital infrastructure for MDA data collection? And so, if by infrastructure the questioner is referring to tablets and phones. So, what challenges exist regarding digital infrastructure for MDA data collection? Christian, over to you.
Sure. So that's a very great question, and thank you for that. It's one of those challenges that we've seen when it comes to infrastructure, especially with digital tools. For instance, the tablets and phones. One of the things we've seen is that for you to be able to have, because of the way NTD is structured first, it's a lot of data and a lot of persons that are responsible for collecting this data. One of the things that we have seen recently and we have used in another project, which is closely related to NTDs, has it's the approach of bring your own device. And in those kind of settings, what has been done is that the persons bringing their device, there are persons who have kind of been lined up also to make sure that they have the specific kind of devices that are required for input for use. Now, having said that, that still is a challenge. There's still a challenge there because it also now poses another challenge that in some communities, like Maria did mention, that the community need to be involved. In some communities, you'll find that those kind of required devices, you may not find them there. It means that the community will now have to source for someone outside their own domain to be able to support them, to be able to collect this data. So it still remains a challenge, yes, but a way around it is that because you can't purchase 1,000 phones, 2,000 phones, 3,000 phones, you can't purchase all of that. However, you are able to use that approach to make sure that where it's available, it's being used. And then where it's not available, then you have to find an alternative, probably have someone who is close to the community to be able to provide that kind of support to the community, while encouraging the community also to be able to find someone who will do that. Then final point is that you also would require that when systems are being set up, let it be set up with at least the minimum required kind of devices that is available at lower levels. So we do not build systems that it will be difficult for those who end users to be able to use them because the devices are not meeting the requirement around that.
Thank you very much. This is very helpful.
Yeah.
So the next question goes to Maria. Maria, there's a very interesting question regarding ethics. Is it possible to waive an ethical review process for a retrospective case control study when the participant provides a consent form? So a participant wants to know that if a participant provides a consent form or at least signs a consent form, does it mean that you waive the ethics review process?
No.
If it's a retrospective case control study. Please, you can just answer and provide some clarity on this, because I think sometimes it can be very confusing for some of the attendees. Over to you.
Okay, so my approach to that question would be, when it comes to ethics, there are different bodies that you need to satisfy the requirements, because again, this is patient data, this is community data, and there is so much that can be fetched from this kind of data. Now, when it is retrospective data, once you satisfy, in the setting of Uganda, for example, on the ethics review board, once you satisfy the different review board requirements when it comes to the data, of course, you have to go through like presentations and what you're going to use the data for, and they assess your study and notice it is not going to cause any harm to the communities you're studying, then you can waive if it is respective data. And also if you're working with very huge data sets, in instances where you cannot track the patients individually. But then there are some instances when you can't. So I think it is not a one answer to it, but it depends on the context and also the objectives of the study and different things that get into some of that assessment. Maybe another person could respond to the same, but there are instances where you can't skip the ethics. And I think it is only right that the ethics are taken as seriously. Yeah.
Yes, Maria, thank you very much. I'm going to ask if any of the panelists has an answer to this or an opinion they want to add on to what Maria said regarding this. Of course, Maria, because you invited them, so that we put we close it out on this particular question. Any other volunteers? Yeah, Pauline, please go ahead. We'll be happy to hear from you.
Yeah, it's just very quickly to indicate that even that waiver is provided by, a body, and my Maria, did like express very well. But it's just to say, even that waiver, you have to apply for it, and a decision has to be reached by, an ethics committee or, a particular directorate of research office, whatever is applicable in the country. Yeah.
That is quite on point. Thank you very much, Pauline, for that. There was a very interesting question that I want to probably also ask Maria, and I think just a second, it may have. So the question is that what processes are in place to ensure data quality before it is used to inform policies and interventions? What processes are in place to ensure data quality? I'm sure the whole spectrum, so from the very beginning all the way to the very end. And this question will go first to Maria, and I will also make room for others who would want to add on and present a unique perspective to also add on to this question before we hang up on it. Yeah.
Thank you so much. When it comes to data quality, there are so many points we can look into, but I can give one. We can have, for example, dashboards that flag. For example, if you look at date of birth, we know that the average time most of us maybe in the current generation live is about 100 years. So you might find that at some data point, the data point was collected and it's reflecting that this person is about 500 years. Like just some of these different flaggings, because I've worked with data and sometimes I notice that in some of the collections, that it is unlikely that a male will be pregnant, but somehow in the data collection, there is a guy name, and then there is gender as male, and then there is pregnancy as one of the variables. So already, I think in some of the data quality checks, we can have some of those flags. Like the moment we see a male is having pregnancy or a male is breastfeeding, then we instantly flag that and go back to either the paper that this data was collected. So there are just some of those at the point of data collection, at the point of analysis, before we get into using this data for policy. Because if we start to plan for males that are getting pregnant, then we are getting off the track. That is just one of the things. And of course, looking at the missingness, some of the data that is being missed. I think this comes back to the point of when the data is collected, people need to be explained to provide as much information. Those variables need to be captured. So the data analysis, the people doing the data analysis can decide what variables they're going to use for particular projects. And that feeds into, of course, policy and implementation. Maybe I'll pause it at that and allow another person to respond. Thank you.
Hi. If I can just add, one simple question. Data quality can be assured through a process of scientific rigor. It sounds very simple, but there are things that can be done in order to ensure that the data that we churn out, the data that we harvest, analyze, analyze and use for decisions are the right kind of data. And one of them that you may want to look at is even laboratory data. We go and collect samples, be they lab for blood spots for LF or urine for various kinds of analysis. We just do not use that. We also ensure some quality assurance. We also do some quality assurance tests by taking a certain percentage of the samples and giving it to another lab or something like that. WHO, working with countries, has a system for ensuring that quality of data, which again needs to be validated at the end of the whole process. If you go collect data from wherever, you go through all the scientific rigor, and you realize that even the results at the end of it all does not just make sense. It might require that you go back and re-evaluate what you went to do. So it goes through discussions, and I just think that you need to subject it to that in order to be able to use it for policy, to explain things to the policy makers and influence those policy decisions. And that's my 2 cents. Thanks.
Yes, and maybe just to add briefly, before I think data is used in the downstream analysis, I mean, there is a process of data cleaning where we can look at outliers, all of those things. Data cleaning can get into aspects of harmonization, making sure the data is reflective, and so different aspects. But thank you, Nana, for adding on to that. Yeah.
All right, thank you very much, Nana and Maria. So Nana, my next question goes to you. Someone wants to know, from your experience, can CDDs deliver all 5 PC NTDs, including trachoma?
Absolutely, absolutely, they can. And currently that is what is being done. Because with the right kind of training, with the right kind of training materials, the CDDs, even in some communities, you may, in fact, that was in the past. These days, it's very rare to go into a community and not find somebody who is lettered, as we often say, or somebody who is schooled. But when the NTD program started with ONCO and LF, you could go into communities, and we say the NTD communities are at the end of the road where vehicles never go to. And that's what also got me into work in public health. And so they found a way of pairing such people who are not educated with sometimes even teachers who come in occasionally to help with the work. And so it's very possible. And now a lot of all the 5 PC NTDs, it started with ONCO, LF came on board, schisto and soil transmitted helminths, and then trachoma. And I know you asked about trachoma because antibiotics are involved in trachoma treatment. When we started the programs, they had to pair a health worker with, or a nurse with a community drug distributor to go in to distribute trachoma drug, that's Zithromax, in the communities. But how many are the health workers? They found out that at a point in time, that was just not possible. So training for the CDDs was improved so that they could go in and undertake the training themselves, based also on the fact that even mothers, uneducated mothers, go to the hospital and get given antibiotics to go and administer at home to their infant children. So then what prevents these same mothers from giving even Zithromax to their children? Once they know the dosage, how it's given, once they've been packaged appropriately in the right, whether they are tablets or it's a syrup. So with the right kind of training, this is absolutely possible. I don't know if I can also go to the next question, which says, when you mention digitizing community registers, what exactly do you mean? Exactly that. Particularly, some communities actually piloted the use of cell phones in collecting the kind of data. They may have the app that helps them to collect the kind of data that we put in registers. And it's even easier to transmit that to the next level of the health system, where it will be compiled and then reported on and used to take the appropriate decisions. Having said that, I've also worked a couple of years ago, I worked on the development of a digital tool, very much like, what do you call it? This instrument, like, the Apple thing, or I've forgotten what we call it, but to collect data. And it's very simple. It was supposed to be a very simple tool that helped these distributors to tally the treatment that they. So it didn't necessarily even involve entering the names of individuals that had to be treated, but actually it's just numbers. How many people have been treated? How many tablets they take? Noting that it's either LF, Onco, or Schisto that the community was being treated for. And so, and at the end, it would populate or add things up for you. It did not, they were doing it such that it did not actually require internet access at all points. But the data could be collected in the community, then sent back to the next level where data access was possible, or cell phones were possible, so that it could be transmitted to the next level without passing over the device to them. It was a digital tool. I'm trying to remember what it was called, but it is possible to be able to do that. I know the development was stalled at the time, maybe because they found out that the devices were going to cost a lot more unnecessarily, as against the use of the registers. So we still have the registers in use, but who knows? In the not too distant future, we may be able to come up with something that's very simple, something that's very cost effective, and can be used for community level work with adequate training. That is very, very key. People need to be trained on the use of these devices. Thank you.
Thank you very much. Probably I will ask Pauline to maybe just speak to this before we move on. Pauline, over to you.
Yeah, I think it was actually a very excellent question, and Dr. Nana has handled it very well. Just to present that we do have indeed guidance in the NTD program manager manuals on how NTD programs can go about this. With recent interest in integration, we've seen a lot more innovations from countries that have had to suddenly integrate new programs, identify new platforms, and therefore solutions are coming locally from countries, and we are learning from those countries as they go into areas, NTD programs with polio platforms and so on. And so it's an area that where we look for innovations and to learn a lot more from the countries on what they identify for integration in a country-specific manner, and where we have the new challenges on what can be co-delivered, what medicines can be co-administrated or not, and then provide technical guidance and review and provide technical guidance for the same. But it's an area we continue to learn.
Thank you very much, Pauline. So what I will do now is to give each presenter the opportunity to have some final words and address our vast audience from all over the world. And I think Pauline will end it with the chairperson's remarks, and we pull the curtains on today's webinar. I will probably once again start from Nana Kweku and move on to Maria in that order.
No, okay. It's just to say that whilst I personally believe that the primary focus for us should be on achieving the goals of the 2021 to 2030 WHO roadmap for NTDs, and this should inform all our actions in efficiency creation, impact creation, to achieve the control of these diseases. And really, cross-programmatic collaboration is essential, and that actually is vested in partnerships. And there will be challenges. There will be challenges. We're already halfway through this 10-year strategic plan that was put in place, but we need to work at it, and I'm sure we will get there. Thank you.
Thank you, Maria.
Yes, mine is to, of course, caution the data capture processes, because most of the discussion we've had is around the data. So getting good quality data feeds into having good results, good analysis, and also informs the downstream research that can be performed from such data. So taking in mind that every data point reflects a patient who has a whole story, who wants to be better, and putting the capture and the cleaning processes and analysis with such intention. Together we can have clear systems that are communicating to each other and, of course, eliminate neglected tropical diseases. Thank you.
Thank you very much, Maria. I will go on to Chicks. Chicks, I think you're muted, so we can't hear anything from your end at all.
Oh, thank you. Sorry.
I can hear you now. Yeah.
Thank you. So it all starts from the community. Let's go down to the community. That's where the data comes from. Get it right at that level. There are so many discrepancies at that community level. That is where the corrective measure should begin. Let's pay attention to the community. How accurate is the population we're getting at sub-district level? Let's pay attention to it. How have we strengthened that data capturing system at that community level? Those tools we're talking about, how community friendly are they? Are the community members able to use it and use it efficiently? Can we find tools that can be used by the common man in the community and give us the right kind of data that we need? And let's eliminate, if we have the means of eliminating the different layers that only increases data entry errors along the way. From community, you have to aggregate at ward level, at frontline health facility level, then you go to the local government level, then the state level. All this increases the chances of error. And I think we can make it if we strengthen the community to generate our data directly from the community to the platform. That would be great. Not also forgetting that there is a huge health intervention burden on the health facility level. Each of the health facility overseeing these communities are usually very, very busy. So can we begin to push advocacy for a dedicated data officer in each health facility to oversee, especially for NTD? So NTD programs across the countries in Africa, this is a take home, this is observation from the field. This, I think, if we're able to do, we will end up with very good data that we can take informed decision, program decision with. Thank you very much.
Thank you very much. We'll take the next one from Christian.
Yeah, thank you very much. And just two key things. I for me to take away from here would be one around collaboration. I think Dr. Nana did mention this earlier on. Collaboration is one thing that would also help. There are a lot of systems, a lot of processes, a lot of structures that has been laid down, that have been developed, that have been set up. I think it's now time for us to begin to collaborate with one another, leverage on what is available, what is on ground, and then see how to chart the way forward. The second one would be to look at around health system strengthening, ownership by the government system, sustainability, because without sustainability, if there's no sustainability, whatsoever we build, whatever we set up, whatever we put on ground, will become very challenging to have a continuity, and that's how it becomes another fragmentations we keep having. So I think around that will be for us to look key into health system strengthening the existing health system, making sure that those who require to have them, the required knowledge, the required expertise, the required capacities are being strengthened. And I think that will really go a long way, counting on all the other things that have been mentioned to be able to get us to where we are heading to. Thank you.
Thank you very much. I will take the next submission, which will be the final one and the chairperson's remarks on behalf of all of us here at the ARNTD and the entire organizing team putting this particular webinar together. Over to you, our dearest Pauline Mwenzi.
Thank you, Anthony, and dear colleagues and friends, as we conclude today's very rich session and discussion, I want to sincerely thank our speakers, the participants, and the ARNTD team for making this webinar both timely and highly relevant. I hope you have all been as informed, challenged, and inspired as much as I have, from the speakers to the very progressive and thought-provoking questions posted in the Q&A. We have been reminded throughout the session that data is not just an administrative requirement, it is the lifeblood that our NTD programs, of our NTD programs, and helps to guide the planning, improve targeting, strengthen accountability, and underpins the advocacy for the resources we need to meet our 2030 elimination targets. And very quickly from the presentations, a few key takeaways that emerged. One, we have made remarkable progress, and we need to really be glad about that as a community. Moving from paper-based fragmented systems to digital platforms, GIS tools, innovations like real-time data dashboards and drone-assisted deliveries, and now AI tools, and so forth. And these are examples from across the continent that show that technology is no longer the barrier it once was. We have also seen that there's need for regional leadership, and ESPN has been very well placed to play this role through tools like the ESPN NTD portal, IU Planner, ESPN Collect, that have helped countries to visualize, validate, and use data at subnational levels. And this has very much strengthened our decision-making, improved transparency, and built technical capacity across the region. But most importantly, data must remain in the hands of the countries. National ownership is not negotiable. Countries must be in the driving seat, as we've always presented, setting priorities, deciding how data is shared, and ensuring it is fully integrated into national health information systems. External partners and platforms, including ESPN, are only here to support, not to replace that country ownership. We've also seen that challenges still remain to be addressed: interoperability gaps, capacity constraints, inconsistent internet coverage, and underutilization of available data sets. And these require sustained investment, political commitment, and a shift from seeing data as a reporting tool to seeing it as a strategic asset. But the way forward is clear. We need to continue to strengthen country capacity and leadership in managing and using NTD data, promote centralized interoperable systems owned by ministries of health, and leverage innovations like AI to and predictive analytics to anticipate and respond to transmission trends. And so the message from today, I think, is simple and clear, that data is only powerful when it is owned, trusted, and used by those closest to the problem. I think I want to repeat that data is only powerful when it is owned, trusted, and used by those closest to the problem. And so let us all remain committed to ensuring that every data point generated by whatever we are doing, be it research, supports country-led decisions that move us closer to elimination. And on this note, I want to thank you all for your contributions and engagement today, which I have thoroughly enjoyed, and urge us to carry this momentum forward into action at national and regional levels. I thank you.
Thank you very much, Pauline. And on this note, we'd like to end this webinar just a minute under our time. Thank you so much for joining us from all over the world in different time zones. We look forward to future interaction in future webinars. We will be sharing all the resources from today on the ARNTD website. And so look forward to that. Immediately it's uploaded, we will share an email to all of you notifying you about this so that you can access the presentation and the content that we shared today. To our panelists, we could not have done this without you. And to our team in the background, you know, working the magic to make sure that we stay afloat this past 2 hours to deliver on this, we thank you sincerely. On this note, we'd like to say bye-bye to you all and appreciate your time here with us.